Good afternoon, everyone. My name is Luisa Baldini. I'm a former BBC correspondent, and I'm delighted to be leading this conversation with our panelists, who I'll introduce in a moment. A panel on precision medicine for vulnerable populations. Precision medicine has the potential to reduce population health inequalities, but only when biology is seen in conjunction with access to quality healthcare and social determinants of health. As things currently stand globally, genetic testing and the translation of those results into meaningful therapeutic opportunities are often unequally distributed. Some marginalized communities disproportionately experience harm from genetic studies and fewer benefits from research due to the challenges and barriers in accessing personalized medicine and the current global lack of representation in reference databases. To discuss these challenges and propose solutions from a policy perspective, we're going to be looking at where emerging genetic and epigenetic technologies should fit within this paradigm. So let me introduce to you our panel. We are joined firstly by His Excellency Professor Mohammed Al-Mahid. The professor has more than 3 decades of experience, both nationally and internationally, with governments, with NGOs and the private sectors in healthcare, sports medicine, anti-doping and humanitarian fields. He is the chair of the Anti-Doping Lab Qatar, Director General of NAUFAR, the Wellness and Recovery Center, and Director of the Center of Metabolism and Inflammation at University College London. Welcome, Professor. Also someone you know, Dr. Vidya Muhammad Ali, Scientific Advisor at the Anti-Doping Lab here in Qatar and Deputy Director of the Centre of Metabolism and Inflammation at University College London. Also joining us from the UK, Professor Sir Mark Caulfield, who is Professor of Clinical Pharmacology at Queen Mary University of London. Sir Mark oversaw the delivery of the 100,000 Genomes Project, which is a healthcare transformation applying whole genome sequencing to rare disease, cancer, and infection. And joining us from the United States, last but not least, we have Dr. Jiling Shen, who is an expert in precision medicine for cancer and accelerated drug discovery from Duke Cancer Institute in North Carolina. Thank you for joining us, panel. Now, we're going to kick off the discussion here on the stage, but please do think of any questions that you want to put to the panel. You will have your opportunity. We really want to hear from you, and I'm sure you do as well. So, in the meantime, let's kick off. Professor Mahid, would it be right to say precision medicine is so much about context, and so how does that affect its distribution or use in vulnerable populations?
Okay, first of all, I think
Thank you.
You know, first of all, when we say, I've been in, as you said, been in this field for a long time, we always took it for granted to say, you know, we provide really personalized kind of medicine. But actually, we build the whole system based on we make decisions based on trial and errors within an environment of one size fits all. We name our disease on symptoms, like when you say asthma or something like this. And when we do investigations, there is a preset kind of things. I remember in our hospital, we just tick. This is the type for this type of disease. We take, you know, a form and we do it. And then when we treatment, we actually give everybody the same treatment, and we try it sometimes. Increase the dose, reduce the dose, whatever it takes. And certainly we had this kind of the coming of first the whole genome sequencing, you know, which was nearly completed 2003, but actually being completed only January this year. And that's close, yani, just. And then you've got the 1,000 genome came in. And then we were able to make a catalog of over 88 million variants. This actually gave us a lot of things to be able to compare and to identify people with a specific disease, or they have it or they don't have it. And then also the advent of coming in of the GWAS. So the whole thing, there is a progression there, which is really very recent if you think about it. But it gave us a lot of knowledge on the variations between individuals, and a lot of knowledge about the disease and its genetics origin. Remember, all this coming in at the same time, this revolution into precision medicine came with other revolutions coming in, other omics that can give us a lot of phenotypes and knowing and understanding. And then you've got all this medical information systems, bioinformatics, our ability to connect all this data around us from personal behavior, environment, and, so it's allowed us so much information that we understand about our patient, and we can really be more precise on the way we manage the patient. So it is not one size fits all, but really as it is being defined, that it is you have the right treatment at the right time for the right person. So that's particularly what's led to all of this in a short period of time. So it gave us this opportunity. But the problem is, healthcare is a complex thing. It is not what you call it, it's not a linear issue. It's about the complexity of me as an individual, biologically. The way my environment, where I am in, how do I interact with it? Then the healthcare services I interact with, if I have access or not, I go in, all these kind of things. There is so many factors that really impact my health outcome. But the problem, there is an inherent bias within the system as well. And the bias in the system, that our references that we have for, if I have, the references and the standards we have are based on even the ones that we think we all know, the white blood cells, the hemoglobins, the vitamin Ds, or something like this, are really not exact fit. For example, somebody coming from my ethnicity or something like this, because it's mostly based research done in the West, If we take precision medicine, okay, it is an opportunity. But if we continue the same line, that's to say, okay, we do our omics, we do our genomics, we do all our things, but still keep within that bias within our sample populations. Okay? And the problem is we are doing that. Actually, it's been estimated between 75 to 90% of the studies done on omics are white populations. 10 to 15% are, we say, Asians, which is mostly, developed Japan, Korea, China now. Well, some Arabs and Indians, okay? And maybe 2 to 3% or something like this, Africans. So it's really not a representative. So if we continue like that, we are doing the same mistake we've done before, and we continue with this inequality and making it more difficult to catch up. So for us, is there a hope? I mean, if the system is inherently like this, I say yes. we can adjust it. Maybe you're going to ask this, but I'm going forward. Okay. Is to say, yes, there is a chance that, because always it gives you a lease of life. When there is new things coming up in your strategies or you want to do something, you need to look at it. What's the opportunity there? Okay, the opportunity there is that we say, okay, we're not going to make the mistakes. I need to have my research into this omics and all my precision medicine program within a country. I really need to include, proportionally, all the relevant groups, all the disadvantaged groups. So I have them there. I need to build an infrastructure. Before you can do anything, there must be an infrastructure in your institutions, within your country, to be able to utilize this. You have to have your bioinformatics. We suffer now, especially, let's say, in this country at least, we suffer finding really good bioinformaticians, So you need to have that. Same time, you need the physician sitting on the, bedside, really understand, to be able to take this and use it.
Professor Mahid, thank you so much for this overview. Let's zoom in now and talk with Dr. Vidya Muhammad Ali about a specific context, a specific situation, and that is the Precision Medicine Initiative for Migrant Workers here in Qatar. What are some of the main outcomes? Tell us about how it's been working and the outcomes.
Thank you so much for the invitation to be here and especially to talk about this. I wish I could actually tell you the outcomes, but what we will tell you is that it's been set up and how difficult it was to set up this program and where we're at with that and how we could perhaps take it forward. And I'm hoping that some of our panelists will really, and I look at you, Mark, particularly, will actually help us take it forward, much more. So this initiative that we're talking about are migrant workers. And we've actually carried out screening of 25,000 of them. I mean, we started our collaboration back in 2008, but we'd been independently working on the mainly South Asians because Professor Madid was actually heading, at that time, president of the Qatar Red Crescent Society. And they were actually the people who were providing the primary health care for this. So we've now collected from this, piggybacked onto the Supreme Committee for Delivery and Legacy, because they were going to do a detailed screen on the migrant workers who were building the infrastructure for the World Cup. So we used that opportunity to actually collect more than just, because, the samples for the DNA extraction, proteomics, etc.
And just to be clear, this is a population of people that you class as vulnerable?
Yeah, they're lower middle income because they're the migrant workers over here. And we're talking about the guys who are building, the infrastructure here. So they are either semi-skilled or unskilled and of the lower and middle income communities. And they are actually not just the vulnerable population in Qatar. I have to say that they are pretty much a vulnerable population back where they come from. And they're mainly from India, Nepal, and Bangladesh, our biggest numbers over here, this 25,000 that I'm talking about. We can then use these omics to really home in on the diseases that are really killing them, and killing them very young, because they're between 25 to 45. They have diabetes, they have heart disease, they often have fatal. Mark, you would know, because you see plenty of them in QMUL too, and in the surrounding area. And they really die of fatal heart disease. It doesn't take that long for them. A huge burden on any NHS, definitely a burden here in Qatar, because you have to treat them and continuously, because it's a chronic disease. Yeah, so that's basically, in a real nutshell. I'll give everybody a chance to, that we've collected this sample. We were very lucky that it had Her Highness Sheikh Moses, because Professor Madid actually presented the project, and it had her blessing, her backing. So it's now been adopted as an independent project of the Qatar Precision Medicine Institute, and all the whole genome sequencing is going to be done on about 5,000 of them. We're talking about tens of millions of dollars already. We're really, the recruitment cost about, I think you said, Prof. M, about $5 million, something in that region. The whole genome sequencing for 5,000 is also not a small sum, again into the millions. And then, so we've gone from the 25,000 to representative 5,000. And then we're doing metabolomics. In fact, we've done the metabolomics on 2,500 of these, but we've kept them representative throughout. And when I mean representative, it's really about age, where they actually come from, so if it's Nepalese. And the groups we thought, look, they're 25 to 45-year-olds. You see them everywhere. And we thought they're going to be really, fit guys who are really not at all. You know that. And a good number. In fact, I was just on the phone to somebody who was asking about the report and says, this can't be right. It is right. 30% of them, 40% of them. If you look at Asian classification of obesity, 60% of them are actually overweight or obese, and they have diabetes, significant number with diabetes, with hypertension. So we really want to know, some of this or a lot of this is known. We wanted to move beyond saying, okay, Asians, South Asians, get more obesity, get more diabetes, get more, why is where we are now. And we hope with precision medicine, we can answer that. And one of the things that Prof. M was saying is it's just not going to be feasible to have personalized medicine. So it has to be stratified medicine. We hope to be able to get to at least the halfway house with these guys. And I have to mention one thing, is that this is singular. It's a really rather unique initiative that Qatar has taken on board, because no other country is offering. They're having a hard enough time getting healthcare for these migrant workers everywhere, including in the UK. But now when we're talking about precision medicine, migrant workers, this is unique in this population. So we hope that we'll be, it's a relationship, Prof. M is usually telling us, this is a relationship between the Indian subcontinent and the Arabs that goes back centuries, with the Indian Ocean trade. So we want to make sure that we're both kind of looking after each other.
Fascinating insight into that initiative. Thank you. So, Mark, you were the chief scientist for Genomics England, a non-profit company run through the Department of Health. From your experience, do genomic technologies have the potential for actually widening the health divide, potentially?
So depending on how they're applied, it is possible they could widen the health divide. But I think in this panel and in people committed in the field, democratization of access for all communities, wherever they are, has got to be the number one priority. So the 100,000 Genomes Project, for people who don't know, was sequencing as much as you and I can read today of your and my genetic code, and that makes you the individual you are, but can also carry susceptibility to disease. So the video was just referring to how that's being applied here in Qatar to advance our understanding of ill health prematurely in young people. And so in this case, we were focused on rare disease, cancer, and infection. And in rare disease is a form of vulnerability because the population with rare disease in most countries in the world had previously been underserved by genetic testing. So many people went through their lives without getting any diagnosis at the level of the genetic test for why they were like they were. And a third of children with a rare disease will die before their 5th birthday. And although these are rare diseases, because they affect large sections of the population, 1 in 17 in the UK of 67 million people, there's over 3 million people with these diseases living with them. Here in Qatar, it'll be a similar proportion, it may even be slightly more. These are vulnerable people because they often don't get a diagnosis, and at the end of whole genome sequencing, we were able to bring live a genomic medicine service that now offers democratic access across the whole of England, Scotland, Northern Ireland, Wales are about to join in. So that means that we can now have a test directory at national level, so there will be equity of access to those vulnerable communities. But picking up the earlier points very eloquently made about diverse communities are now, should be the #1 priority for us. This is about enfranchising the whole of humanity. It can't be right, as you very correctly said a moment ago, that only 3% of the world's genomes come from African populations, especially not if all of us here, whether we know it or not, probably originated from Africa, and they have the most diverse genomes. So imagine that sequencing people of African, East Asian, and South Asian descent, and other populations around the world, can add to our understanding and actually solve problems in other communities. So the addressing of vulnerable people not included here to date is a priority. In your opening, you mentioned epigenetics. Epigenetics, and as two of the panelists have already mentioned, other omic measurements. These might be measuring proteins, there might be metabolic signatures in body fluids, there might be measuring the RNA, which carries the message from the DNA to make the protein. All of these are in scope now for being used, and where this type of what's called multimodal data, because we're using several modalities, is gathered together, you begin to get a much more granular understanding of the disease process, because the genome sits at a bit of distance from where the biology is actually going on. It kind of sets the scene and is the code for what might happen. As you get closer to where the biology is, the bigger the effect of the thing that you're measuring. And we see that, for example, Vidya was referring to metabolomics or metabolic signatures in body fluids. That is quite close, and we see very big effect sizes. So the future of understanding how our genome and us interface with lifestyle and the whole of the lifetime experience and exposures that we get is about studying a full range of the omics, and particularly enfranchising diverse communities across the world.
So, Mark, thank you very much. A question now for Dr. Shen, but in the meantime, please, we will be opening up to the floor. If you want to ask any questions, then you will have your opportunity very shortly. Dr. Shen, much of the current focus of precision medicine involves developing new drugs for personalized treatment of cancer and other diseases, as we know. How can we better leverage innovative solutions to increase the access to precision medicine?
Great, Louise. Thank you for the great question. And also thank you for the other panelists that set up the stage. And I'm a technologist, right? So, besides cancer, actually, I directed the Duke Precision Medicine Center. I led several consortia. So it's really also have a broader perspective about diversity. I think there's several things we try to address, again, from our angles, developing new technology to address the limitation of precision medicine in terms of diversity. One is try to further address the implicit bias, right? There's a notion that, oh, you do precision medicine, there's no bias, the genome tells it all, but actually that's not true. But also second is how to translate knowledge into actionable items, right? How is it going to benefit to the patient rather than tell them, say, look, you're unlucky because you have that mutation, too bad, right? So I want to kind of give a couple examples. First is, the previous speaker also talked about, right, besides genomics, the omics, like epigenomics. For example, I have funded a research by Department of Defense, actually looking at migrant workers in the United States, which is more Hispanic origin. And kind of shows a common pitfall, right? When we look at these workers in North Carolina, they had a much higher rate of all kinds of diseases, but also deformed, babies and autism from kids and inflammatory. And if you do genomics, sometimes the problem with the genomics, right? We have 20,000 genes, and you are looking at like 5-6 traits, and oftentimes you always can find, because the sample size is small, right? So you're going to find some genes associated with that phenotype, and you say, look, it gives us a very easy answer. Say, look, these people have higher disease rate because they have certain mutations. But Interestingly, is when we add in technology on epigenetics, looking at their blood cells, what end up finding is these migrant workers have much higher exposure to fertilizers, including precursors to actually sarin gas, right, which average Americans never had such exposure to. And that's the epigenetic signature is so much stronger than the genomic signature. Because you're going to find a 3% genomic signature, they say, right, that's why they have higher. But if you look at that socioeconomic impact on these people, which could be much higher. So first is really, right, be important to have a holistic view and adding additional omics, as the panelists point out, to really kind of dissect, really genetics plus, kind of other effects that would have an imprint on metabolomics or epigenomics. And the second case is, right, I was leading the National Cancer Institute Patient-Derived Model Consortium and Tissue Engineering Consortium. And some of you probably don't realize is we're talking about genomic sequencing has, the vulnerable population has an underrepresentation. If we think about all the drugs being developed, right, you ultimately have to test drugs on the disease model, for example, like a cancer, you grow patient cancer. In those models, the vulnerable population is even less represented. If you look at this cancer model on mouse, it's 90%, 95% Caucasian, right? And these are the drugs that are going to go to clinic and use on patients. So, the vulnerable population was never represented in the preclinical drug development stage. And in that case, right, what we need to do is, we just have an NCI consortium, and there's going to paper actually coming out at the Cancer Cell, the Top Cancer Journal. First is on both fronts. One is from a funding agency point of view, enforcing rules like, look, if you're going to publish your drug development data, including patient, right, systematic including patient information, like, ethnicity and race and all that, right? But also second is from an incentive point of view. For example, the African-American population in America historically has a lot of history about being used in clinical trial for a lot of unethical, right, things, and they have aversion to join clinical trial, have experiments. So now how can we develop newer technology from a position of personalized technology, say, look, we are really treating you as an individual, right, rather than as this kind of blanket group. And I think that's also very important, as some of the panels alluded to. Sometimes precision medicine also gives us as cues actually to making stereotypes, because you can look at population. For example, the African-American population has higher mortality rate for colon cancer, melanoma, breast cancer, right, all these. And it's easy to look at genomics, say, oh, look, there's something barely over the noise floor because that's why they had higher, but masking the bigger problem of, they actually receive much poorer treatment. And last, just very concluding, right, there's another, in this morning I just spent at a CIDRA, another population, for example, also we are addressing is, let's say, pediatric cancer, right? You mentioned these rare diseases. That's also a population that is not being addressed, right? And if you think of pharmaceutical company, very little effort or resources are put in to develop these drugs because economically it doesn't make sense, right? It's going to take you much longer time to do the clinical trial, harder to get patients, and then you don't make money out of this, right? But precision medicine is potentially the answer to address that, because then if you're treating every patient, right, more specifically, and rather than treating them as a whole group that requires 1,000 patients for you to achieve statistical benefit, then suddenly this becomes possible. So again, anyway, just coming back is trying to address, we are trying to address these issues also through technology, but that alone is definitely not enough. We need a holistic solution that really guided by, efforts from all fronts.
Dr. Shen, thank you very much. Would anyone like to pick up at that point before we open to the floor?
Just one small point, actually.
Yes, just very quickly, Dr. Vidya.
Very quick.
No, as in, before you make your comment, please do ask any questions. And those of you watching online on the live stream, please do submit your questions via the app in the chat box and also down here in the auditorium. If you'd prefer not to raise your hand, there is a QR code that you can scan. Can we see the QR code, please, so that you can actually submit your questions via that QR code. Dr. Vidya.
Yeah. Just really to add on to that more than anything else is the environment that you were talking about, where exposure to chemicals, for example. Here, the exposure is to heat. not every population, say for example, there's a huge interest in the Nepalese. They have, so the heat stress and your adaptation to that heat stress is something, that you can add on, and you don't very often hear about that. So the genomics, along with information about what is the condition under which they are living, becomes really important. And can we explain changes or differences in heat adaptation between individuals by using precision medicine?
Thank you very much, Dr. Vidya. Do we have any questions? Yes, we have a raised arm there. The lady in the white jacket. If we could get a microphone, thank you.
Yes.
Please let us know who you'd like to address your question to.
I actually have, my name is Diana. I'm specializing in health economics and pharmacy. And we actually have research on evaluating the cost effectiveness of precision medicine in oncology. And we find out, our research, mainly that precision medicine isn't that cost effective currently. So this can be addressed by any one of you, basically. My point is, usually precision medicine ends up with prescribing targeted therapy, and those are not cheap. So for the Nepalese patients that we have, you're currently scanning and finding out what's the cause, you probably will be ending up by prescribing something or referring it to something, give him something that won't be cheap. And I'm not sure how the government will cover this, actually, especially in oncology. The NCCC now is not given the patient, especially non-Qatari, the same amount of support they used to give them before, especially for targeted therapy. So I'm not sure how this will be solved. The second thing is that precision medicine isn't really representative. You only represent yourself. And the more we do the tests, the biomarkers, we see more people, more subgroups or micro subgroups. So for example, trastuzumab causes cardiotoxicity. We scan for cardiotoxicity, we end up with other subgroups, and subgroup, we end up with one patient only. And this can affect the clinical trials, this can affect the pricing of the medication. So how do you address these issues when you advocate for precision medicine specifically? And thank you.
Thank you. Who would like to answer? Dr. Shen first.
No, that's actually an excellent question. It's actually kind of, at least even from my perspective, the first question, right, kind of the economics of precision medicine for oncology. There's threefolded. First one, as you correctly pointed out, right now, if you look at patients who benefit from sequencing and finding a mutation, it's actually about 10%, right? Because the majority of patients don't actually have a mutation that you have a drug targeting. So you're going to do this expensive test, then going to have the same treatment going forward, number one. And second, you also kind of touch upon a very important question, which is if you think about in this field, right, when you're developing such precision medicine, if you talk about the total economics, at least in the United States, okay, in a single payer system like UK is very different. But in the United States, there's only economic incentive if it is opt-in, but not an opt-out, okay? What opt-in means, it only kind of has appeal if that bring a new drug to the patient. If you're an oncology patient and the assay telling you, say, look, don't take this drug, right? But I don't have a better alternative. As a patient, are you going to take that device, right? Probably not. So again, if you think about it, one side in a way that only adding costs because you're bringing new treatment, but when you try to persuade people not to take a patient, not to take a treatment, but without a better alternative, and that don't quite work out, right? And also same thing for the farmers. If we are a pharmaceutical company, what you're interested in is a precision medicine that allow me to bring my drug to the patient, right? It's not about persuading a patient not to take my drug, right? So there are these economics that's going to work out. Now, with kind of but ultimately it's going to bankrupt the health system, right? We all know that. But you say the only solution is having value-based system where, right, you say, look, there's an overall population and you cannot overtreat. But for cancer, it's always a hard case because you can't put a price on people's life. So to address that, I think what we have to do, as a precision medicine is go beyond just adding a new drug to treat every single mutation. That's where we're going. But but building more sophisticated predictor, right? Saying, look, there's 100 drugs out there, and you might be more responsive to this one, but not that one, so we can avoid unnecessary treatment that costs a lot of money. So yeah, with that, I want to hand to the other panelists. But excellent question.
Thank you, Dr. Shen. So, Mark?
Just one or 2 points on the health economics of this. So in the UK, in the National Health Service, we have a national genomic test directory. So every cancer patient should get the same test wherever they are. And it's reimbursed only if you use the test directory. So if you use something else and you do your own thing, you won't get reimbursed. So, and that test directory is now reviewed annually. Targeted next-generation sequencing panels are the widest used test in cancer, and that is partly for the reason you say, which is the economics of a whole genome being applied is not quite there. However, there are a number of things we've detected that could allow the avoidance of harm. So, for example, we're now deploying testing, it's not a whole genome, but routine testing for a particular change in DNA that can make you susceptible to toxicity from 5-fluorouracil and capecitabine. This is called DPYD. And that testing is now universally available before patients go on to those medicines. And therefore, we are subsetting, as Xing says, we're subsetting a group of patients who probably shouldn't have the medicine or are at increased risk of harm and maybe need a reduced dose. And some of that harm is quite expensive. It's hospitalizations, it's possibly ITU if they have multi-organ failure. So when we look at the cost effectiveness, we need to look at the total societal cost, in my view. But you're absolutely right, a whole genome is not affordable yet in widespread use in cancer.
Yes, please.
Yeah, I think, look at the development of healthcare delivery over decades. In the beginning, always there is a high cost. But everybody said, the healthcare system in Qatar is based on data that we need to develop for ourselves. We really need to understand, I mean, we did some work, vitamin D, for example. Everybody is vitamin D deficient, 90%. So, you know, it's really we need to understand. The more we can understand, let's say we have what, Arabs, South Asians here or something mostly, and another minority, we need to understand this. Then if you really give a good treatment, the patient doesn't come back to you. You solved it. As he said, now it's try and error, so sometimes you give it, doesn't work. We actually started the precision medicine in Nofar. This is a substance misuse or abuse, maybe, in Qatar. It's a wellness center. And we are putting precision medicine there. These are neglected groups and usually stay with you for possibly ever. They need that contact, something. There isn't really. We need to understand them more. And it's a small population, but the effect we could, if we could, how many hundreds of millions of people all over the world. That's a field we could go. These are disadvantages. As I said, so you can impact, it costs a lot of money to treat each individual person there. If we can really understand, and it's a discovery, it's a journey, it's in every field. But if we understand our population in Qatar, not just in oncology, but it's also in other fields, we can be very effective in everything. We don't have to repeat things. We see the patient 10 times. And possibly we could cause harm. We don't know.
Thank you very much. That's answered the first part of your question very adequately. What about the second half? Do we need to hear a bit more about that? About the non-representation?
Yes. So the new thing is that we have the Microsoft groups now, and the Microsoft groups are not representative of the population. So like you said, when we have a drug that is not safe for that group and drug that is safe for another group, should we raise the price for the ones that it has the safety superiority to make up for the ones that not safe for them. So the pricing of the medication itself differs, because for some people it will be a burden on the healthcare system, but for the other it won't be. So this is, and should both groups take the medication or not, especially in the oncology, because it's like life or death situation. So some people even insist, even if they know it's bad for them, but it's their only option. There's no other way for it. So once we do the testing, what implications that we have after the results? It's not the test itself that is burdening, it's the interpretation of the test that is burdening. And that's my question: how can we avoid such situations? Thank you.
So Mark?
We've looked at 76,000 whole genomes, and 99.5% of us, doesn't matter what ethnicity you are, have at least one gene-drug pair where if you come across a medicine, you may be harmed by it or it may be ineffective. So 25% of us possess 4 of these. So in one way of addressing your question is not to increase the cost in certain sectors, but to actually understand the architecture of the medicine's response and to use more information. So to give you a specific example that's relevant to Vidya and myself and others here, we've recently looked at a medicine that's widely prescribed called clopidogrel, which is used as an antiplatelet therapy for people who've had a heart attack or had acute coronary syndromes. 30% of white Europeans don't activate the drug, so it's never going to be of any benefit to them. Most international regulators and guideline bodies have rather weak guidance around this, but last week we discovered in a study in East London that we have of 50,000 people from the Bangladeshi and Pakistani community that actually in South Asians, the variant that does variants that don't activate the drug are present at 57% frequency. And we're giving this medicine all the time. So one way we can save money is to understand the architecture of response to medicines and appropriately tailor the medicines to the right patient first time and not give them to people who are going to get no benefit. And there are widely discussed quotes that about only 30 to 50% of the medicines work in the patients they're given to. So we need to be more intelligent, but I would counsel against increasing the cost of a medicine for one section to address a problem with another section, because I don't think we should use that economic route to do it.
So Mark, thank you very much. Did I see another hand up? Lots of hands up now. Okay, let's try and get a couple more in. A gentleman at the far end there, and then the lady here. So we've just got 3 minutes left, so if we can try and answer these succinctly. Thank you.
Hello, everyone. So thank you for this amazing subject and great panel. Now, my name is Dr. Nuraldin Alderi, and my question is concerning precision medicine, not only for oncology, which is unfortunately always the interest of medicine, and to provide treatment despite not being the most, let's say, price effective in most cases. But in other conditions, like, for example, precision medicine in autism, for example, or for neurodevelopmental disorders, which affects a large population of people and children. Now, my main question is why there is more interest in one field rather than having it for other fields as well that would benefit more individuals, in my opinion. And in some way, you mentioned that for oncology, it's always one treatment. So precision medicine would actually defeat the whole purpose of precision medicine if you always provide them with the same treatment.
Sorry,
that's
if we
pretty
can
much
just
my question.
Yeah, so your question is, why is it mainly directed to oncology? Why aren't we seeing it in other areas?
Can you hear me? Yeah, it's certainly being pushed out to other areas. I mean, I mentioned diabetes, heart disease is really a big area of interest. Perhaps it's not discussed as much in this panel at the moment. We've just given examples of these, but it certainly is. The other thing that I think, Prof. M, I don't know if you want to say, for example, because I have people from NOFR here sitting, about the substance abuse. Now, there is a drug that's used for treating opioid, addiction. There, it's not about the drug itself, it's what's the dosage. So we will know that certain people are fast metabolizers or slow metabolizers, and if you'd had a gene screen, you would know, actually, you know what? Don't give the guy buprenorphine, because you're going to have to hit him with such a big dose, and you probably think he's just not responding, or he's not adhering to whatever they're advising. So there, it becomes really important. There are lots of other, examples like that, but because cancer is the biggest killer, then it does kind of get more press time.
Thank you. And very quickly, please, if we could keep it brief. Thank you, Madam.
Thank you. Thank you for a wonderful presentation from all of you. It feels like science fiction in a funny kind of a way. And I'd just quickly like to ask the panel if we could put you in a time capsule and send you 25 years into the future, what do you think the impact of precision medicine would be on healthcare?
Well, it's in the English NHS now, so I think it'll be substantial in the future. But I do think that we need to look at multi-omics. I think a genome's only one facet of the outcome here.
Dr. Shen, last word from you.
Yeah, I would say is, that actually going to become the norm. Just like nowadays, you go to a hospital, it's unfathomable if you don't wait away, they do the blood, right? But if you think about 50 years ago, 100 years ago, right? Doctor look at you, Chinese medicine kind of touch your pulse and somehow gets all the information from that, right? So I think at that time, we just take as a norm and say, look, this is actually a standard procedure you do, and they're going to direct you to the treatment.
Thank you, Dr. Shen.
Really quickly, again, going back to my ethnicity, I hope it's no more at that time papers or discussion about, oh, she's Indian, so she's going to die by 50. And I hope that we will have a mechanism why, and they will actually treat us accordingly. That would be my dream.
Thank you. And Professor?
I think it's maybe how we started in the beginning, because now with this information system going on in the world, and all this data is being collected, even from your gym equipment, for let's say, or something like that, from the environment, from everything, and it will be on time. That's the science fiction of it. But at the same time, it's connected also to everybody else, not just in your country, in your society, but everywhere in the world. Will allow researchers, especially with artificial intelligence now and all these big data management kind of capabilities. And I think with technology becoming cheaper in the future, I mean, how much was it, the first genome? 10 billion? Something like this, 3 billion, yeah. And now you can do it less than $1,000 or something like this. I think $700 when we negotiated the last time. Okay, so things is going to become cheaper, which is the normality of life, but all this connection with the rest of the world, the capabilities, as I said, artificial intelligence, we're going to be there. The issue is, some of the question there, I felt, sometimes we are the enemies of our own selves by saying, oh, that's difficult, that's expensive. Look, you do the first steps. We collected our samples, we didn't have any money. We have to put our own money to buy -80 freezers because we couldn't lose our samples. And then we said, okay, how are we going to find the money? What I mean is, take the first step and go beyond it, and you will find a way to find it. And I'm sure these guys before us, and thank you very much.
Thank you, Professor. Thank you very much. Hopefully we'll all be around in 25 years to see for ourselves the effects of precision medicine. But for now, thank you so much to our expert panel, Dr. Xiling Shen, Professor Sir Mark Cofield, Dr. Vidya Mohammed Ali, and Professor Mahid. Thank you very much, and to you.